I thank Dr. Himanshu and all the panelists for such an extensive discussion. Moving on to our next session, I invite to the podium Dr. Saurabh Taneja, our next moderator, who is a senior consultant, Institute of Critical Care Medicine, Sir Gangaram Hospital. Dr. Saurabh is the recipient of multiple awards, including the Vishisht Chikitsa Ratna Award by DMA and Chairman's Appreciation Award from ISCCM Delhi NCR. Welcome, sir.
नहीं बाहर से इनवाइट कैसे करूँ मैं? Can I have the CV of my panelists, please? Yeah. So it is my proud privilege to invite Dr. Prashant Saxena. Sir has been a dear friend and mentor for long, and he is the Senior Director and Head of Pulmonology Critical Care at Fortis Hospital. He is currently the Chairperson of the SCCM Noida Delhi branch, and under his leadership, we won the Lifetime Achievement Award. Dr. Prashant, please. Next, I have the privilege to invite Dr. Sanjit Sasidharan. He is the Director Critical Care at Raija Hospital, Mumbai, and he was the past president of Indian Society of Parenteral and Enteral Nutrition. He has 102 peer-reviewed articles and textbooks. Dr. Sanjit, please. Dr. Ghosh is not there, so please you can skip this. Yeah. Next, I have the privilege to invite Dr. Vimi Rewari. Ma'am is a professor, Department of Anesthesiology, Pain and Critical Care at AIIMS Hospital, and ma'am has done a Commonwealth Academic Staff Fellowship from St. James Hospital, United Kingdom. Ma'am. And I would like to invite the main panelist, the guest of honor here from Dr. Pradeep Rangappa, sir. Sir has been elected as the President, Critical Care Medicine in the recent elections, and I have been his student through YouTube videos, and I think we all are. Most of us have watched his videos through the last almost half to 1 decade, and I have been constantly learning from sir. Yeah. Thank you, sir. Thank you. So, to follow Dr. Himanshu Diwan is a tough ask, but I have made this presentation just for postgraduates, so it is a very basic one as compared to the hi-fi rash. So, it's a just 28-year-old male patient. He presents with fatigue and malaise for 7 days, low-grade fever for 5 days, and yellowiness of eyes for 3 days. So, typical patient, many of our patients present to this having fever with yellowish discoloration. I avoided the rash because the previous session was on rash. So my first question to Dr. Pradeep Rangappa sir is, so when such a patient with fever with jaundice presents to us, what are the broad categories of diseases that comes to our mind as a first thought?
Yeah, thanks, Saurabh. So obviously when you have such a situation, you think very broad. So we would categorize as whether it's infections, whether it is drugs, or whether it is autoimmune, or whether it's a part of the overall systemic problem. So I think as the case is more on liver, so obviously would look at infections pertaining to the liver. So it could be tropical, so where again you would divide into whether it's bacterial, viral, and parasitic is also common in India like malaria. So you would think of hepatitis A, B, C, D, E, any of those. Herpes simplex is something I want you all to keep in mind, because herpes simplex, we had one case which we have published, herpes simplex coming with fulminant liver. So often we overlook that as a possibility. And please remember herpes simplex. You can miss it and patients can die. So we have published one case where herpes simplex going to fulminant leading a liver transplant. So please remember that. And drugs, the common drugs, of course, we have acetaminophen and INH. If someone is on ATT, it can cause. And even mushroom. We had one very affluent VIP patient coming with a mushroom poisoning and dying in ICU because he had it in an exotic sort of a restaurant where he was invited by the chef to have this mushroom. And he died, and it became a big news. It came in papers also. So these are, and wild mushrooms are notorious. So that is something you need to keep in mind. And autoimmune, we have to broadly look into whether Wilson's, because that is something as intensive, it's very hard for you to think about. And there are other metabolic conditions which you may have to think of, and autoimmune sort of liver conditions. And it can be as a part of a broad sort of a systemic problem like sepsis, veno-occlusive disease. And now in this day and age, you have to think of oncological also, because many a times you would have underlying malignancy which has progressed and which can present with the liver dysfunction. So these are some of the broad categories at least we would look into, and then you will be guided by your investigations and clinical examination to try and delineate whether you are dealing with which category and take it from there.
Thank you, sir. So first message for postgraduates is, when the patient comes to you, think in a broad spectrum what all this patient can have. Try to make a differential. This will help you in real life as well as in critical care. Yeah. So as the patient presents, his fever was temperature around 100 Fahrenheit. There was no chills and rigors. The jaundice was noticed 3 days ago, progressively deepening as told by his family members. It was accompanied by poor appetite, nausea, and one episode of vomiting. He had dark urine and pale stools and no abdominal pain, GI bleed or confusion initially. So Dr. Vimy, can you guide us? Any other history do we want to take about the basic history? Yeah.
So in the ICU, I think for the trainees, one thing that is often neglected is history taking, and especially here, like Dr. Pradeep has already highlighted, the majority, there are a lot of reasons for a patient presenting with fever and jaundice. So your purpose of history taking should be to rule in or rule out all of these causes. So you start with the fever, so the type of the fever, whether it's continuous, it's intermittent, it's with chills and rigors. So the patient doesn't have chills and rigors. So if the malarial fever, it's occurring every other day, it gives a hint towards the diagnosis. Then the jaundice, whether it's is associated with pale stools, so that points you towards an obstructive cause of jaundice. Then you come to the risk factors or the exposures which can possibly lead to jaundice. So the various causes, the blood-borne causes where, there is history of blood transfusion, or there is use of IV drugs, unsterile syringes and things like that, which can transmit infections like hepatitis C and HIV. Then any exposure to vectors like mosquitoes, which can lead to dengue and malaria. Then exposure to animals, so that could lead to certain diseases. And then you talk about the drug intake, like very important, drugs like ATT, one of the very important causes of acute liver failure or jaundice in our country. Then history of any, alcohol and substance abuse, very important. So all of these things need to be documented. Family history of history of other family members having jaundice. So that could point towards a fecal-oral route of infection like hepatitis A. So I think that is the majority of the questions that need to. And in drug history, one very important thing that is emerging as a very important cause of jaundice is intake of herbal medications and diet supplements. So that should be elicited. That history should also be elicited.
So thank you, Dr. Vimy. So history taking is an art which is often forgotten nowadays. So we should talk to the family members, talk to the patient, take a history in detail, take the history of present illness, and take a past history, take a drug history. Try to rule out causes, as ma'am said. So this is where you can rule out causes very easily if you ask specific questions. And also take an epidemiological history where the patient is staying, what is his eating, especially in patients with fever and jaundice. So after history taking, next comes examination. So Dr. Sanjit, how would you proceed with examining this patient? Just the basics, sir.
Good morning. So sorry, when you said history taking is an art that's forgotten, even examination is an art that's actually forgotten. In fact, Osler's once said, that we may miss more if we do not see and examine rather than not knowing stuff. So overall, I think this is very basic, and it gives a lot of clue as to what's happening on these patients. So skin is something that we look at to begin with. We look at everything that looks from icterus to petechiae to understand what's happening with respect to the severity of the condition. And then when we examine, we look for the heart, we look for the usual parameters that we look at. But on jaundice, we actually look for spider angioma, we look for pulmonary edema, we would look for clubbing, we look for things like that. And when we go down into the abdomen, we look for signs of ascites. I mean, we would look for medusae, we would look for dullness, we would look for the art of percussion is kind of gone as of now. If somebody asks a junior how how to percuss, they would probably not know that it has to be percussed from the top to down and down to top to actually figure out liver span. So the examination largely has actually been replaced in modern ICUs with POCUS. I mean, that's what's changed everything. And the moment we put POCUS in feature, we realize that the examination is going out. But POCUS, nevertheless, is probably the best thing to do in such cases because we get a spot understanding of what's happening, especially when you want to look at the gallbladder. So the moment you want to look at the gallbladder, you know the size, the weight, the wall, and the common bile duct, which actually helps us to delineate between two main causes, which is either obstructive or non-obstructive.
Thank you, sir. And very rightly said, examination and ultrasonic examination should be combined nowadays, and it does give a lot of clues. So what are the initial investigations that should be sent, Dr. Prashant?
I think it's a case with a young gentleman presenting with fever and jaundice, icterus. And there's no, on examination, there's no other systemic signs except for a hepatomegaly. So we'll do the usual stuff, the CBC, the KFT, LFT obviously, look at the coagulation screen, and definitely look at the peripheral blood smear. And initially I would still send the usual tropical fever panel to look at if any other that is brewing inside. So the usual initial investigations. I would also order an ultrasound, X-ray to see the liver and the chest once.
So when we had the investigations, these are the LFTs of the patient. AST of 1420, ALT of 1580s, ALP of 180, bilirubin of 9.2, direct is 5.8, albumin is 3.4, and INR is 1.5. So when we look at this set of investigations, Dr. Sanjit, what is your first impression?
So definitely this patient is having transaminitis. There's no doubt about it, and it's more than 10 times the upper limit of normal. So it's something that's really very acute. The only difference is that the INR has remained at 1.5 and really not gone above 1.5. It's kind of borderline when you look at coagulopathy. And since there is extreme transaminitis, it always goes towards a pathology that is acute. And one of the pathologies that we would look at would be viral hepatitis, given the scenario that what we are looking at here. So a normal alkaline phosphatase that you showed over there would actually kind of rule out an obstructive pathology per se. And since it's an acute manifestation, even the chronic things like pancreatic cancer and obstruction and all those things would move off. This is an acute case, probably related to either drugs or it has to be viral.
So this definitely tells us that it's a hepatocellular pattern of injuries and narrows down the differential diagnosis to acute viral hepatitis, some drug-induced ischemic hepatitis, or a metabolic disease. So next question, Dr. Prashant Saxena, is, which you already told us, what all investigations do we look forward to make this etiological diagnosis? So we found this pattern of injury, we have sent some investigations. Do we want to add some investigations on the next day?
Yeah, so the patient is appearing to become sick, and definitely there is a hepatocellular injury and coagulopathy. So definitely hepatitis screen, all the viral markers including HIV and all the hepatitis A, B, C, E, and definitely vasculitis markers. At this stage I would send a ANA and anti-mitochondrial antibody as well. And the young patient is there, so we should rule out Wilson's disease. I would send a ceruloplasmin level also in this patient.
So we send all the investigations and hepatitis A IgM was positive, others were negative in this patient. So on day 3 of admission, the patient develops confusion, disorientation, asteresis is present. His INR, which was normal initially around 1.5, has increased to 2.8. The bilirubin has increased, but the AST, ALTs are falling. Ammonia is risen to 150 micromole per liter. So we make a diagnosis of acute liver failure, hepatitis A etiology. And when we talk about acute liver failure, we classify them into hyperacute, acute, and subacute, depending on the days from jaundice to encephalopathy. In hyperacute, it is less than 7 days. In acute, it's 8 to 4 weeks, and subacute is 5 to 12 weeks. So to Dr. Pradeep Rangappa, what is happening nowadays? The patients are being admitted in the wards. So this patient was initially supposedly admitted in the ward. What parameters should be monitored in the ward, and when are the classic signs, or what are the symptoms, or what are the criteria that the patient to be shifted to the ICU? Sir.
Yeah, so I think very clearly, I think this is the bane of current sort of a clinical care that is being provided, even in a so-called good hospitals, that there is no business for this patient to be in the ward, because INR more than 2 itself is a red herring, and you are talking about fulminant, they need to be in ICU very closely monitored, because once you have INR more than 2 and getting into some sort of an encephalopathy, these are all warning signs, and the mortality, as we know, in fulminant liver failure is very high. I mean, it was 80%, now slowly it is coming down because of the liver transplant centers. In fact, this patient has to be referred as a possible potential for needing a liver transplant. So they need to be obviously shifted to ICU with all multimodal standard ICU monitoring. And because the commonest cause of death in fulminant liver failure, if you look into the evidence, is predominantly multi-organ dysfunction. So you need to really keep a tab on all the organ dysfunction that are happening, and they have multiple other intercurrent events in the form of hypoglycemia, worsening brain edema, bleeding, so on and so forth. So need very close monitoring. So there is no rocket science in it. They need to be shifted to ICU. I think ward, that itself is a red herring, and it's a warning that they shouldn't be in the ward. Sure.
Very rightly said, sir. But nowadays the patients are in the wards and high dependency units, and we should be very careful. As soon as we see any of these signs, any of these things which is a red flag for us, INR, patient moving into encephalopathy, patient having signs and symptoms of hypoglycemia, hemodynamically unstable, multi-organ dysfunction which is starting to appear, we have to shift the patient in ICU, if not earlier. So we should be very clear about this fact. So Dr. Prashant, what should be the initial line of treatment, and is there any role of N-acetylcysteine in hepatitis A liver failure?
Yeah, so I think it's what the basic treatment of these patients going into encephalopathy and related to liver injury. So definitely look at the ABCs first, look at the airway, breathing, circulation. And if the GCS is low and the patient is unable to protect the airway, we should definitely electively intubate the patient, not only to protect the airway, but also to limit the rises in ICP, which may happen later. Then looking at the circulatory dysfunction, pretty common, because these patients have hypoalbuminemia. You are rushing a lot of fluids, they can go into pulmonary edema very fast. So that is the key. So we have to obviously have invasive monitoring and trying to limit the mean arterial pressure in a range of 65 to 70 maybe. And obviously electrolyte disorders are very common, and these patients may have coexistent dyslipidemia, which needs to be corrected, monitored very frequently. They may have a issue with the low-lying blood glucose level, so definitely regular monitoring of blood glucose. And then definitely we need to assess the blood gases, look at sometimes they may be hypovolemic. In these patients, lactate may not be a good marker because it's elevated due to the liver dysfunction, and you have to use multimodality management of this patient. Then subsequently, this patient, as we have done a few investigations, this patient definitely needs further tests and viral screening and maybe a drug examination of the circumstances, maybe some injection of some drug toxins, toxic screen we can send along with the autoimmune markers. And definitely, as I told you, ICP is an issue. And we normally are not doing ICP monitoring. We don't do it in many ICUs. It's not being done. So it's just examination which is going to help you trying to limit the pressures. For patients who have a sodium level which is not, they usually present with hypovolemic hyponatremia or euvolemic hyponatremia. So these patients need to have a sodium levels close to 150, 145 to 150. So we use prophylactic 3% saline in these patients. And if they are tending to develop ICP rise on the 3% saline, we use mannitol in addition to that. So that's how we treat, plus cultures and all those things, and that is a parcel.
There is no role of prophylactic antibiotics even in this case. So I wanted to emphasize this for the
Sorry,
students.
the NAC, it is recommended in acetaminophen related liver injury. Recent reports have suggested that even in non-acetaminophen injury, you can use NAC. There's nothing against it. It is not going to harm you. But the evidence is not robust.
So there has been case series, and NAC is now being used in almost all cases of liver failure.